Hey, well, welcome everyone. Thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. A quick footnote, I've been on active surveillance since 2009, and I'm still a member of my local support group that got me started on this journey in the first place. Our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment, but a management plan. I would like to remind everyone we are not anti treatment, but anti unnecessary treatment. We are not here to dispense with any medical advice. Nothing said during our meetings by our speakers, ASPI, or the audience should take the place of consultations with your medical professionals. So you can submit questions in the chat box, which we will try to address. Please keep your questions limited in scope. Our speakers do not have the time to review your case history. At that time, you can also click the raise hand button from the bottom of the Zoom window toolbar. And if there's time, we'll try to call on you. And please keep yourself muted during the meeting. The speakers presenting here today are generously donating their time, and we want to be respectful of that. This meeting is being recorded and will be available on our website in approximately 1 week, and you will get an email notifying you when it's ready. Also, if you subscribe to our YouTube channel, you'll automatically be notified when a new video is posted. So without further ado, we'll have a quick few words from Howard Walensky, the organizer of this meeting. He will introduce our guests. So relax, enjoy the meeting, and I hope you leave a little bit smarter. Take it away, Howard.
Thank you, Bill. And thanks everybody for coming. Today's webinar is entitled Why All Men Diagnosed with Prostate Cancer Should Undergo Germline Genetic Testing. I'll try to say that faster, but I don't think I can. We based the title of the program thinking about the idea of universal germline testing. This testing tells us what mutations we've inherited from our parents and how that might impact our prostate cancers. A couple of examples are BRCA2 and Lynch syndrome mutations. We'll be hearing more about these mutations from our speaker. I will tell you a little bit about our speakers today. Each will talk for about 15 to 20 minutes. If you have questions, post them in the chat box, which is being managed by Jeff McLennan and David Keller from ASPI. I have to mention that we had to change our lineup a little bit because one of our speakers got delayed by storms going from New York to Myrtle Beach, and he was going to be our lead off. So instead, we're going to have Dr. Paller from Johns Hopkins speak, and I'll tell you a little bit about her, and a little bit about the other speakers, and then we'll speak, and we'll interject questions between speakers. Dr. Channing Paller is a medical oncologist at Sibley Memorial Hospital and an associate professor of oncology at Johns Hopkins University School of Medicine and a lead investigator of the Promise study of genetics in prostate cancer. Promise is enrolling 5,000 patients with prostate cancer for a free germline spit test. Yes, you can spit for science, and it's okay. Their aim is to recruit 500 patients with mutations. And I'll put up the link. I've already put up a link for a study aimed at Hispanics. A researcher had read the announcement and asked me to give her a plug, Stacy Loeb. So I gave Stacy a plug. So we'll start off with Dr. Channing talking about Promise. Then, depending on whether Dr. Shore, well, we'll go to questions. Then we'll go to Dr. Shore if he arrives. If not, we'll go to the other Neal, Dr. Perlman. So Dr. Paller, the floor is yours.
Thank you, Howard, for that wonderful introduction. I'm excited to be here with all of you because I think not enough attention, as Howard was saying at the beginning of this discussion before we started officially, is paid to active surveillance. I think in breast cancer and other tumor types, a lot more attention is paid. And so I'm thrilled that we're here talking about different genes such as BRCA and Lynch and what can we do to help ourselves and our families. So let me share my screen and change it to the other mode. All right, everybody see what they're supposed to see now? So I was asked by Howard to talk about the Promise Registry, and I'm excited to do that today. Before I do that, I just want to make sure we are all sort of on the same page. It's been a long time since high school and biology. And so the way I think about cancer as a medical oncologist, so usually my friend Stacy Loeb or Neal Shore, other urologists join you, but I'm a medical oncologist, so I see cancer either in a multidisciplinary setting or once it's spread, patients with prostate cancer come to me as the director of prostate cancer clinical research at Johns Hopkins. And so the way medicine's been done is you have a cancer or a problem. We say, here's your therapy, here's your pill, here's your injection. And we say, well, there's a third of a chance it'll work. There's a third of the chance it won't work. There's a third chance it might do nothing. And oh, by the way, there's a third of a chance it might have some bad effects. You might have some neuropathy, you might have some diarrhea, you might have some low immune cells, but take it because we don't know what'll work. And that's the only thing we have, right? It's kind of scary where medicine used to be when I was entering medical school at Harvard in 2001, right? And we've come a long, long way from that. And one of the ways that we've come a long way from that is targeted therapy in addition to targeted therapy to your genes, not just radioligands, not just other targets. So how do we think about it now? So now we use blood, saliva, tissue, and we figure out what genes are in your body. So what genes your mother and father gave you, your genetic information that you were born with, and what genes developed during the lifetime that your cancer was on this planet. So your cells at some point, if you have a cancer, mutated and developed a secondary mutation, and those are the somatic mutations. And so to analyze people's cancers, we really want to understand them. How aggressive are they going to be? Are there any germline or somatic mutations? And so we do these analyses. And with saliva is an easy way that we can get your germline mutations, your genetic information. And so we take that information, and then based on your genes, we find the right therapy for you so that everybody can have the benefit of an effective therapy with better quality of life and fewer adverse events. So that's really where the field has moved to. And it is almost fun because I can really help people in a targeted way. We have many trials open now for people with BRCA mutations and Lynch syndrome so that I don't need to give them hormonal therapy and castrate them and lower their testosterone, and I can still control their cancer. So that's part of the fun of my job is that I get to do clinical trials where I can really target people's cancer with the least amount of side effects. All right, so let's go over basic differences. So for germline testing, guideline recommendations are for high risk, very high risk, or metastatic prostate cancer patients. Jewish ancestry, this is an old one from NCCN, but we now know even Beyonce's dad has BRCA1. So families with high risk mutations or positive family history is who should do germline testing. What you notice here is not you guys, not active surveillance. And what Neal Shore and I care deeply about and have written about together is that even in this group, there's 1 to 3%, not the normal 10 to 15%, but there's still some people for a $300 or less dollar test could find out that they can make a difference for themselves, their trajectory, in their cancer, and their family. And so I think it really should be in every type of thing, but I understand why it is not currently recommended. And some people find it not cost effective. And thus insurance does not always pay for it. And the reason why I made the Promise Registry and brought Heather Chang in is because I thought it was needed and I wanted everybody to be able to participate. And then we have somatic tumor testing. So this is things like BRCA, also 1 and 2, many of the same ones, as well as other ones. are important. And this is considered for all men with metastatic disease. All right, so the Promise team, who are we? So many of you know, I won't play the name game because I you're international, but many of you know my colleagues. And so Heather Chang and I were doing germline genetics. She is the lead in germline genetics. And I found myself with a bunch of trials back in 2019 and 2020. By myself as a manual antennaropist, took off to go to Minnesota in terms of what do I do and how do I test people when nobody's paying for it? So we raised money and found some funding partners with Advancing Cancer Treatment, which is philanthropic partners. There's no pharma involved. And we said, hey, can we buy 5,000 tests for gentlemen around the country? And can we learn more about germline genetics? There's no germline genetic registry out there. Can we start this in the US and can we make a federated program internationally with our colleagues? So that was really my hope of how do I find these people to go on these trials so that I can give them targeted therapy so that I don't have to castrate everybody unnecessarily. It was a little bit selfish for my trials and a little bit of like, what would I want if I was in that situation to really treat people as well as possible so they could live as long as possible in the healthiest way possible. So as you can see here, color is our partner. They're not allowed to use your test. They're not allowed to give it to your insurance, to your company, to your doctor, unless you approve it. We have an institutional review board as well as all of our own institutions. Prostate Cancer Clinical Trial Consortium is the coordinating center. Heather and I are the lead PIs, and our funding partner is Advancing Cancer Treatment. So the name, we're into fun acronyms at Hopkins, is a prostate cancer registry of outcomes and germline mutations for improved survival and treatment effectiveness for the Promise Registry. It's really simple. You get registered, you learn if it's right for you. If you have any sort of prostate cancer, even in active surveillance, you have biopsy-proven prostate cancer, you are eligible, even if there's no intention to treat you. We give you the DNA kit, we ship it to your house, and then a few weeks later, you get the results. I warn you all, it's often in your spam, so check your spam or contact us and we'll help you find it. And it's really that simple. And you can go over the results with a genetic counselor, all free of charge, all from the comfort of your own home. It was made during the pandemic to be pandemic friendly. All right, so things that to think about. One, we didn't have and we needed a germline genetic registry to learn more about mutations besides BRCA, BRCA, to learn more about mutations besides Lynch syndrome. There are a lot more out there that we think we can treat and help that we're not getting the attention that they deserved because pharma didn't have a budget for them. And so we wanted to help study those mutations. So that was sort of the main reason to make a registry. This also provides free genetic testing and germline counseling to participants at no cost. You don't even have to have insurance to participate. And it takes patients with eligible mutations and we follow them for 20 years, some sort of long term. That's what Heather and I committed to observe patterns, outcomes. You know, as patients get different therapies, is there hypothesis generating information that comes out of this that will help us design our future clinical trials. Case studies we can share with the community for CHEK2 patients or Lynch syndrome patients or other mutations that we can help and sort of share a community of information. It's a virtual study, so consent and surveys are completed online. You do not have to leave your own provider, and we are enrolling for about another year and a half. So our anticipated accrual was we had estimated 5,000 individuals, but we've already hit that. What we didn't properly account for is that some people start the process and don't finish. Some people get the kit and get distracted by life and don't complete it. And so we have not yet. So even though you'll see we've hit 5,000, we have not hit our 500 with pathogenic or likely pathogenic variants, and germline variants of uncertain significance. So although in one sense we're ahead of schedule, we're really just on time because we're still accruing our patients with active mutation. You must be over 18 years of age and have documented prostate cancer by tissue biopsy, PSA over 100 at one point in your life, which hopefully was never you guys, or imaging. So localize that you're following an active surveillance. Absolutely, we invite you to participate. BRC, biochemical recurrent prostate cancer, and any of the states and any histology as well is welcome to participate. All right, here's our roadmap. We wanted to bypass the doctors because nobody was seeing doctors during the pandemic. We opened in 2022. So we did direct outreach through patient support groups, through marketing, through Facebook, and through clinicians. Participants could self-consent from their own house, from their own phone. And then we would provide them with a saliva kit and they would ship that in. If their test result was positive, they could review the results with a genetic counselor. They were invited to participate, nothing mandatory. If you want to get your results and run, absolutely fine. But we invite you and hope if you're positive, you will participate in twice a year, allowing us to collect information from your physician and asking you about how you're doing with patient-reported outcomes. We also provide you free of charge educational newsletters and webinars to keep you up to date on what's been published in the field and what's new, especially for patients with mutations or other targeted therapies. And for those who are negative, we will return the results. And then you also have genetic counseling for you and your family. And you also have access to the newsletters should you want to participate. Oftentimes I find patients saying, well, can I opt in anyway? Because I might get one of these mutations as a somatic mutation later, even though I don't have a germline mutation that I was born with. And I said, of course. All right, so which are the tests we test? So you lucked out. When we were negotiating the deal with Color, we test for all the genes because it was the same cost as testing for just the prostate genes. So BRCA, the Lynch syndrome, you can see all of the different genes that are suggestive of prostate cancer history, but we test all of them. So it's not, a 200 panel, but it is key 30 genes. Right now, as I said, we've hit over 5,000, and we have 448 participants who are eligible, for which we can get their records that follow up and show up at a clinic and respond to our emails. So we are making progress, but it takes a little bit to have all of those variables met. We are in the entire continental United States at this point. Very exciting. And you can see many centers are helping us with this initiative. So why do we do genetic counseling? Well, it really does provide important benefits. First of all, it increases your understanding. It explains and simplifies the concepts so that you can talk to your family members. So many people I know of my patients who have a BRCA mutation are really grateful to have that extra conversation with the genetic counselor. And then, I've been doing this long enough that I just saw a son that unfortunately developed prostate cancer. And so now I see the son and the father and help them both in terms of management of their prostate cancer. The son's going to go into active surveillance, but for right now, just for sure, because that's what he's comfortable with and that's what he's allowed to do. But it's how do you manage these things? And it helps you learn about your DNA and what you're at risk for and how to handle it going forward. And empowers you to make good decisions, right? Some people with BRCA and breast cancer don't want their breast removed. Some people just want to follow. Some people want their breast removed. So we need to learn more for prostate cancer patients. I think we are behind and we need to learn more who needs to be monitored, what's too much therapy, what's too little therapy, and really understand who needs what therapy. I'm a big fan of do no harm. So I watch and wait with a lot more people than I think my colleagues, especially if it's safe to do so. So it also helps you evaluate your personal and family risk. right? So you need to understand that. And then it allows you to get your family members tested should you be positive. And it provides you with a new and informed perspective to offer your family members as well as yourself. I always like to say to my patients who have a mutation that, it's a silver lining, right? So you never really, really want one because it puts you at risk for cancer. But then it opens up the door for treatment options. Those patients had many more treatment options than the patients who don't have a mutation. So I always remind them of that fact. And again, I love my 92-year-old who was on immunotherapy alone because he has Lynch syndrome. And he came in with a big pelvic mass of prostate cancer, right? And other people said, oh, you have to do chemo and this and that. So there's just really knowing your genes helps you, I think, get the right therapy for you. So to remind everybody, register online, provide a sample, do it from home, keep your existing doctor, and do it all for free. You receive your individual genetic profile information, genetic counseling, information that could impact available treatment options should you need treatment one day, and ongoing updates on prostate cancer, as well as you being incredibly generous with your time and help improve future treatments for your family and for other prostate cancer patients. So I appreciate everybody who participates in research. So we provide resources, as I told you. We provide webinars and newsletters to keep people updated about what is going on in the world. And we have different speakers come from genetic counselors to community to equity people like Otis Browley. We really try to keep it broad. And at the same time, each different session answer a different mutation question to really help educate our audience. We do a lot of outreach. We speak at different events from zero to runs to the FEN session. And so these are many of our supporters. This has been a really positive experience for me, and I think everybody that's participated over the last few years. So I just want to take a second. I hope none of you progress. I hope you stay on active surveillance for your entire life. But should you hit a point where your urologist says, oh, it's time to proceed with considering treatments, I want to give you a flavor of the type of therapies out there that we're helping people match to. So Neptune, it is a trial that is done by Raina McKay. It is nationally available at multiple sites, including Johns Hopkins. And for patients with a BRCA, and they've expanded to all mutations that respond to a PARP inhibitor, all HRR mutations. For those patients who are eligible and going to a surgery, they have a choice. If they have an autoimmune disorder or something and can't do radiation, if they have a small lymph node, choice of doing 6 months of olaparib and hormone therapy, and then getting the radical prostatectomy. So this is the other arm is no olaparib. And it's really to look and see how much we can create a pathologic response for these patients. I want to show you our future study that's coming down the pipeline through the Prostate Cancer Consortium. This is called the ADAPT study. So we are setting up a platform where anybody who is eligible to go for a radical prostatectomy and potentially a lymph node dissection will go to the control arm of darolutamide or apalutamide or one of those, plus standard ADT, so an LHRH agonist or antagonist, as the control arm for 6 months, followed by surgery to try to create a pathologic response, a complete pathologic response, or an investigational arm, which would likely be that plus something else, right? Like the Neptune trial, like the PARP inhibitor, or we'll have an arm for sure for Lynch syndrome patients, right? Can we just do Pembro with hormone therapy? And will that create a pathologic response? And we really don't need to be doing prostatectomies anymore. So this trial will help us change the standard of care for patients with localized prostate cancer with or without mutations. And so I wanted all of you to be aware of this. Should you progress, I want you to know there's good options out there. And these will be available at your local centers nationally and probably some even internationally, as I know there's some international people on this call right now. So with that, I want to say thank you. Contact us with any questions. Here's our website, prostatecancerpromise.org. Please join us. And I want to welcome you to the Promise family. We want to work together to help improve the care for prostate cancer patients. So thank you very much.
Thank you, Dr. Paller. So we'll do some questions now. And then we'll see which Neal is up next when the time comes in a few minutes. I had a question for somebody that's been in the trial. He says, my color genetic test results don't show that I had prostate cancer or that I was high risk for getting prostate cancer. So I was not impressed with the results of the test to predict the future in getting prostate cancer. So I guess the point is, you mentioned a number earlier, only a certain percentage are going to be diagnosed. So the people being disappointed if they don't find the gene.
That's right. I would say let's flip that around, friend, and say, congratulations, you're not at high risk for prostate cancer. So that's the answer you want from this test. You want a negative result. So I'm sorry it didn't impress you, but congratulations. Your risk of having an aggressive cancer present from genes that your parents gave you is very low. So I hear you. I'm sorry it didn't impress you. And I'm excited for you that you have a good prognosis. Right. So we expect to give you those numbers again. Generally, 10 to 15% of people will have a germline genetic mutation, much higher for somatic. But for the active surveillance group, healthy people like you, it's more like 1.9 to 3%. So that was the Bal Carter. He did a huge cohort of like 15,000 guys. And so he had 1.9%. We've seen as high as 3%, but that's where I'm getting those numbers from.
And Dr. Carter was one of the pioneers of the active surveillance. He was at Johns Hopkins as well, in case you don't know the name. I'm going to switch over to, well, I noticed one question and something that you should mention. I'm going to scold you.
Please do.
We're an international group, but you do not recruit internationally.
I don't. Because we had a little bit of trouble getting everything translated, and our IRB would not let us do it until we translated, and we didn't want to pick one country over another country. So that was where we stopped. We are absolutely every day talking about a federated system. So if people can get genetic testing outside another way, we are trying to create a federated database to increase this registry and learn more together. There are a lot of colleagues in Canada and Spain, in Europe that want to participate, and we are welcoming them in. We're just sort of figuring out all of the negotiations associated with that. So that's not yet happening, but it is of interest because I think we will do better together.
Gotcha. Jeff, do you have some questions?
Sure. I have Scott in North Carolina, doctor, asking, now that ATM mutation has made the list, along with BRCA 1/2, are there specific nuances to managing prostate cancer for men with this particular mutation? Are there leading researchers that are focused on ATM mutation?
Absolutely. So we know BRCA 1 and 2 are king and queen, and they are the ones that respond the best to the PARP inhibitors and to carboplatin, chemotherapy. ATM, on the other hand, we are learning, despite it being approved early on, olaparib, and then later for talazoparib and Enza, it is not as responsive to the PARP inhibitors. And so we have many trials out there through the consortium and otherwise looking at ATM positive patients and trying to find better therapies to target their cancer. I will say the carboplatin, the chemo that works on the BRCA mutation, also seems to work for the ATM mutation. So yes, any of the top centers involved in the consortium have experts, and the whole team can see you to address these rare mutations.
Thank you.
Hey, Jeff, can I interject something?
Sure.
And I'll come back to you. But uh, the person with the question mentioned BRCA1, and I had read recently that that had been sort of downgraded or eliminated as a concern with prostate cancer. Do you know about that, Dr. Paller?
Um, I had heard that briefly, that it's not quite as much of a risk. But no, I don't. I hadn't read all of the details about it. It is less, less. I would say that.
So I guess we can call it light. Light.
Yes, yes,
Okay.
yes.
Sorry to interrupt, Jeff.
Yeah, doctor, kind of a broader question. I've read in places like Howard, we're trying to be educated persons, that there are several genes that interact with several cancers, if you will, in the abdominal area. Do you have any knowledge of that and how we might gain from that knowledge?
That is a very insightful question. Not that all questions are insightful, but it is one that we're looking into actively. So I had a patient, my father's friend, who had an MUTYH mutation. And he developed small cell cancer. And there was sort of this fight between a pathologist on the East Coast and the West Coast of whether it was small cell that came from lung cancer or from prostate cancer. And then everybody was saying, wait, MUTYH causes colon cancer. What are you guys even talking about? So a bunch of us around the world got together with Foundation and figured out what germline mutations predispose you to secondary mutation. And so I was convinced, as was my patient, who said, can't you go get your friends together and do this? That MUTYH would then be more implicit in prostate cancer. And it was not, actually. And so we did this big study. I can put my MUTYH paper in the chat if you want. But I was expecting it to be related in some way, but it was not. So that's just one example. There's a lot of other ones going around. Is one mutation putting you at risk for further mutations? And so there is a lot of interplay of sort of leverage that builds up to end up with more severe cancer, and depending on what mutations you end up with over time and what you're born with.
Thank you.
So Jeff, maybe we should move over to David Keller. David,
Yes.
you got a question or two?
One question from George Gillespie, which is you kind of answered a little bit earlier, but he's saying that if you get a negative result on the Promise study and you're not showing up as having any of these bad genetic mutations, does that have any implication on the type of prostate cancer you might end up with down the road? In other words, if they don't have a genetic mutation, does it mean that if they do get prostate cancer, it'll be less aggressive, or there's no connection between the two, really?
No connection.
Okay, that's okay. And I had some foundational type questions for those of us who are the difference between somatic and germline. Could you kind of repeat that for us so we can get that distinction?
Sure. So germline is what you were born with. It's the genes that your mother and father gave you upon your birth. Somatic are the ones that develop later in the cancer itself.
Okay.
Well, let me
Fine.
throw another shoe in there too, because this is at least a three-legged stool. So what are polygenic? What's the polygenic risk score? Isn't that also looking at the DNA?
We lost your
Dr.
you're
Paller,
muted right now, Dr. Paller.
you're muted.
Sorry. Yes. So it is looking at many genes, and it looks at your risk of developing cancer. It is something we are also looking into using this database, but we don't have our hands around it very well yet. We are just starting to look at databases about gathering what is a polygenic risk score of looking at many, many genes and your risk of developing cancer.
Gotcha. Okay, I think we're going to let you off the hook for a few minutes.
I think both Neals are here now.
I'm going to get both Neals are here now.
Yes, Neal Shore and yeah.
Okay, well, we'll go over to Neal Shore then, and I'll give a little background on Neal. Neal is a urologic oncologist and is medical director of the Carolina Urologic Research Center in Myrtle Beach, South Carolina, where he just recently today arrived from New York City. So thank you for that. He has conducted many major studies on medications and immunotherapy that could be significant for patients with low-risk prostate cancer. So, Dr. Shore, if you're ready, all ashore that's coming ashore.
Thank you, Howard. And I think I caught most of Dr. Paller's presentation, which was, as usual, excellent. Our Promise Registry is very cutting edge. I certainly encourage everybody to load up for that. There you go. So when Howard asked me to do this, I thought, well, great timing, because I thought I'd just take a sort of a condensed version of a plenary presentation I did literally, I guess now 3 months ago at the AUA, the American Urologic Association, which met in Las Vegas. The planning committee came to me after many, many years of me lobbying to get a genetic testing topic as a plenary topic. And it's taken me several years, but I was really happy. This year, this presentation was 3-part. It was on, I just wanted it to be on prostate, but for various political reasons, which I won't get into, they said, okay, we'll give you 30 minutes, which I would have taken the full 30 to just talk about prostate. But we also had bladder and kidney cancer. Mark Ball gave a great presentation on kidney cancer, genetic testing, and Peter Black on bladder. And I was the sort of the cleanup hitter, the third one on genetic testing and prostate cancer. That's why it says in urologic oncology. Next slide, please. So this is my presentation that I gave, and we got a lot of really great feedback on it. Next slide, please. So just to sort of recapitulate the question that was asked just a moment ago, there's sort of two ways of thinking about genetic alterations. Some people call these mutations. I think it's kind of we sometimes suffer in medical world of using too many words that mean the same thing or have slight nuances, and we certainly suffer from using lots of acronyms, which confuse not just patients and caregivers, but also confuses our colleagues. So I think try to break it down here so that it can be understandable. Is germline or hereditary alterations, as Dr. Paller said. These are what you inherit from your mom and dad. You get the sperm and the ovum creates the embryo, and that creates your, genetic alterations from a hereditary standpoint. And I think it's fair to say it's around 10%, maybe as high as 15%. I love the reference to Bal Carter from Hopkins, because Bal was my chief resident when I was at New York Hospital at Cornell, and love Bal to death. He's a fabulous guy. But the germline, as you can see here, these are alterations that ultimately, if you've inherited them from your mother and father, the sperm and the ovum, you get a haplotype from each side, which gives you your ploidy or your diplotype. And so every cell in your body, with the exception of your red blood cells, has this alteration, and it's around 10 to 15%. Now, I'm going to go a little bit more in detail with a few more slides later on, but having an alteration, and the common one that we mostly see is the BRCA2, the breast cancer gene or the BRCA. There's other ones I'll show them to you. I think Dr. Paller did as well, that are there and are arguably actionable and certainly interesting and knowledgeable to have, especially for research purposes, sometimes for clinical utility, but very, very importantly, for what we call cascade family testing. I'll get a little bit more into that. I actually think this is one of the areas that are really underrepresented, and I'll show you some data on that. Now, the somatic is basically the tumor tissue. Somatic is another way of saying the tumor tissue. Here's the thing about that. If you have germline and you're negative, and you just said, okay, my germline's negative, and you stopped there, and you went on to get metastatic prostate cancer, and you didn't do the somatic testing, you'd miss about 50% of actionable, clinically valuable alterations. So you don't stop if the germline's negative and you have metastatic disease. That's a guidelines recommendation. Now, if you have germline positive, many of our colleagues will also get somatic because you can sometimes, in a small percentage, single digit, find some other co-location alterations that can be meaningful. But if it's just somatic, you're not passing that on to your family members. This somatic tumor is another way of thinking about it. If you have positive findings, you can select certain FDA, EMA approved therapies. And it also, much like in early stage localized disease with germline and advanced disease with somatic alterations, there is a predisposition for more aggressive disease. But very, very importantly is the clinical trial. ATM, there's several really good ATM specific alteration trials that are underway. Next slide, please. So I began this plenary presentations for my colleagues and took them right into the takeaway in case they zoned out. And I only had about 10 minutes to do the presentation because it was 30 minutes and I had to share it with bladder and kidney. So I said, here you go. Here's the takeaway. Germline testing in prostate cancer is woefully underutilized, which leads to marked underutilization of regulatory approved therapies. The underutilization of individual germline testing thwarts early detection of family members, i.e. children, siblings, nieces, and nephews at risk for other cancers, prostate, male, female breast, ovarian, colorectal, and pancreas. And we can talk more about why that's so important. And germline and somatic testing are the standard of care. Avoidance is not acceptable. Now, I put that out there very full-throated way because the audience was presumably 75 to 80% healthcare providers. Next slide, please. So my goal has been for the democratization or the universal acceptability of germline genetic testing. And so why now? There's a whole host of reasons, and I want to get into this. And I've had pushback from a lot of different stakeholders, and all I think well-intended, but I don't think the reasons are acceptable at this point in time. And as I said, germline genetic testing, or yet another acronym, I apologize, GGT, has been underutilized. And it has been underutilized because many think, oh, if it's only good for someone with a strong family history. In other words, I really know my family history. And I would say that arguably many of our patients and friends don't, but it's only a value if I have a strong family history. In other words, a sibling with prostate cancer, a mother with breast cancer, certainly premenopausal, etc. But the answer is that it's not exclusive to only people with strong family histories, or an early age of diagnosis is the best predictor. And then another interesting thing is it's only really valuable if I have a high grade Gleason score. So, two things right there. Number one, I would say it's not unreasonable in it there to say that 50% of the people that, and I've been doing this for over 25 years, when I do a family history, the husband will say, "Nah, there's no cancer in my family." And then the wife will say, "Your mother died of breast cancer." And he'll say, "Oh, I thought she died of a stroke." Or, and then the husband will say, "No, there's nobody else." And then the wife will say, "Your sister has ovarian cancer." And he'll say, "Oh, I thought she died of, a liver infection or liver cancer." So that's very, very common. And it's not to denigrate men, which I guess I can because I am one. It's just we haven't really been that keen on understanding our family history issues. So the guidelines, which I'll show you in a minute, are highly predicated on knowing your family history, number one. Number two, they're based upon a accurate histopathologic assessment. What does that mean? That means if you're on a scale of 1, 2, 3, 4, 5, if you're a grade 1, 2 prostate cancer, considered low grade, highly unlikely to require prostate cancer if it's localized, the germline. I would argue, having done many of these types of trials for other reasons, looking at histopathology, that in a significant number of patients, particularly in the community outside of world-class academic pathologists, we see grade group discrepancies. Patients who are called having grade group 2 who end up being grade group 4, etc. And previously, there was a very high cost of testing. Lawsuits and patent victories have lowered the price of germline testing in the United States. And I'll get more into that later. But you can get germline testing in the United States for essentially $200 a test. And that's at the high side. Most times, the companies won't even bother with you, but there's almost now universal coverage for it in the US. Challenge outside the US is it's very expensive and cost prohibitive, which is in contradistinction to like everything else in the world, where the US has the most expensive cost for therapeutics and diagnostics. It's a bizarre irony. Um, Previously limited lifetime evidence of cancer, it lacks of clinical utility. I'll get into that in a second. The underrepresentation in the non-European, the non-white population is very real. I'll show you data on that. Next slide, please. So this is right straight from the NCCN and ASCO. Now, you can try to read this, but I put this out here because it's essentially what the current recommendations are right now. And it's confusing. It's confusing to you as a layperson to try and decipher this. Frankly, it's confusing to the average busy community medical oncologist and urologist. The bottom line really is what they're saying here is that don't get if everybody deserves germline testing. Here's the takeaway. Everybody should get germline testing unless if you're grade group 1, 2, and you don't have a family history of cancer. I just got through telling you that family histories are oftentimes very unreliable. They're still not well taken by many busy community healthcare providers, and they're unreliable by the person who's trying to recall their family history. Number one. Number two, the histopathology can vary unless you have the benefit of having a very high quality uropathologist. Thus, the reasoning for taking this, demystifying it and saying, just test everybody. Oh, well, we didn't want to do that years ago because it was a several $1,000 test. And now it's a $200 test, blood-based or saliva-based. In the US, that is. Next slide, please. So this is an interesting a paper that I'm I cite for you here supporting the evidence of universal germline genetic testing. If you look at the bottom cancer types and you read across the x-axis, breast, ovarian, endometrial, colorectal, pancreatic, prostate, and they all really share, with the exception of colorectal, a lot of BRCA2, and some BRCA1, and some other less common HRR, homologous recombinant repair alteration. You see where prostate really falls into that panoply, and then the diagnostic yield, the slide, the graph to the right remains high, even in patients not who don't meet the National Comprehensive Cancer Network criteria. 6.5% to 10.5%. So you're missing that population of patients who didn't meet the criteria. Now, some may say, okay, 10% did, we missed another 6.5%. Well, if you're in that 6.5%, that's a big deal. Next slide, please. So this, if you now look at the where we stand compared to our competitive landscape of solid tumors, breast, ovarian, pancreatic, colorectal, endometrial, we in the prostate cancer community, we don't have a solid recommendation or consideration for a universal germline genetic testing in comparison to these other solid tumors. I just showed you the data that were comparable in the epidemiology. So why is that? Well, it's a flaw. It's a major flaw. So I think that leading researchers and organizations, and I actually now have, it'll be 2 years this fall. I've sent a letter to both NCCN and the AUA to alter their guidelines, and have not received a response yet. Next slide, please. But I was glad we did the plenary and the AUA recognizing this. Here's just again another opportunity which we published and others have published as well, looking at the utilization of germline genetic testing. So it's essentially a non-metastatic in the United States. It's about 1% when we reported this, and about 15% in metastatic patients. That's just unacceptable. Next, please. So why order a test? You know, you order a test, you're going to do something with it, especially if you're asking, insurances and payers and Medicare to pay for it. There has to be what we call clinical utility. So there's a lot of great data that clearly says that if you have a BRCA or an ATM and you have localized disease, especially if you're considering active surveillance, which I'm also, like Dr. Paller, a huge proponent of active surveillance because I'm an acolyte of Val Carter. But if you have a BRCA, that patient may still be appropriate, but you're going to follow them more closely. Or that patient may want additional histopathology or some other molecular testing to say, well, you know what, maybe I should get treatment. And then there's just so many clinical trials that exist. I'm sure at Hopkins, like at our site at Start Carolinas, we right now, I think we have 5 or 6 that are specific for alterations. Specific. You can't get into a specific trial unless you have a type of alteration. This is this very important notion of personalized, precision-based therapeutics. And then this is not a complete list, but these are FDA-approved therapies if you have a specific alteration. And there's tumor agnostic alterations. If you have MSI high or a TMB high for pembrolizumab. We also see this now if you have certain alterations in ERBB2 and HER2, and then other list of all the different alterations for various homologous recombinant repairs, and then ongoing clinical trials. in big unmet needs, as was talked about earlier, for example, ATM. Next, please. So that's the reason, the clinical utility for getting it. Let's talk about these barriers. Well, I already went over it. Complex and conflicting testing criteria. It needs to be simplified and just basically say, if you've got prostate cancer, you must get tested, like we see in many other solid tumor types. It's a $200 test. There should be no insurance discrimination. There should be no life insurance discrimination. Lack of provider familiarity and education, yes, which I applaud the AUA for allowing us to have a plenary, despite the fact that I've been doing testing routinely for almost 8 years now. It's still a paucity of my colleagues who are using it, partially because the reports are a little complicated. There's no some are not understanding of the clinical utility regarding therapies that have been approved, like the PARP inhibitors, and others are not doing clinical research, and others are just too unfamiliar with all this data. Clinical workflows, it takes time to sit and do these reports. Some get thwarted because they feel, well, I can't do this. I must have a certified genetic counselor. Unfortunately, we don't have enough certified genetic counselors to tackle the problem for 350 million people. We have about 5,000 certified genetic counselors in the US, about of which only half do oncology. So you can sort of do the math. The way around that is you either learn in your own clinic, someone takes on the responsibility, or you can also use telemedicine via all of the sponsors. It's become very good. But ongoing education is incredibly, incredibly important. The cost of testing is like I said, and it's a couple $100 now. For some, that's still a lot of money. I almost never see that as a problem, and I don't practice in a very affluent part of the world. Now, unfortunately, outside the US, it's a couple of €1,000 in Europe. And why that is beyond me. And you're not allowed to send blood or saliva overseas for regulatory purposes, which I think is should be overcome. Next, please. So we did a trial called the Proclaim trial. We did this during COVID. This is really one of the first prospective trials of 1,000 patients. And we basically got germline testing on all patients with prostate cancer. We had one academic center of 15, it was NYU. And what we looked at is the efficacy of doing patients who met NCCN criteria versus not. We basically tested, we asked everybody to test everybody and anybody with prostate cancer. We subsequently reported our first findings in European Urology, and then a second publication a year later, and how it impacted clinician management in Journal of Urology. We just had a third paper looking at the patient standpoint that's been accepted in prostate cancer and prostate disease. It's not online yet, but should be from the data from this trial within the next month. Next slide. So essentially, what this study was, very simply, and I encourage you to read it, was if you look at the patients who were in criteria, who met the NCCN criteria, remember that slide I showed you earlier, which said test everybody except if you're grade group 1 or 2 and you don't have a family history. And what we found was there was really no statistically significant difference between if you're in criteria or out of criteria. And it's interesting, you see the different alterations that are noted there from CHEK2 to BRCA. Interestingly, we did also see some patients with MUTYH as well. Next slide, please. So really no difference. So therefore, to me, that teaches me that NCCN is overly restrictive. So the takeaways from the paper: PGVs, pathogenic germline variants, with prostate cancer has utility across the disease spectrum. In that group, we looked at metastatic, we looked at biochemical relapse, and we also looked at localized disease. Actionable pathogenic germline variants are missed by testing, particularly in the non-white Black population. Fascinatingly, the incidence, and I didn't show this in this slide because of time, the VUSs, the variants of uncertain significance, meaning we don't know what to do with it, but when more testing becomes available and analysis, sometimes a VUS, a variant of uncertain significance, can become a PGV. The VUS rate was double in the non-white versus the white population, because the overwhelming majority of our knowledge of the assessment of both germline and somatic has come from white European populations. So there's a lot we can learn in both the Black Latino, the African American, and certainly Asian American populations, and many other variants of those populations. So to fully realize the benefit, our conclusion back in 2023 in European urology was comprehensive testing. Next, please. And then Howard wanted me to just mention this paper, and I'm remarkably proud of this paper because we published this in JCO Practice in 2024, and the title speaks for itself. Implementation of universal germline genetic testing into the standard of care for patients with prostate cancer. The time is now. I would encourage you to read this paper, but it has luminaries who all signed on to this, including Dr. Paller, and the majority are the smartest, the most accomplished academic medical genitourinary oncologists who said the time is now. And there's a complementary paper by a very good friend of mine, Andy Armstrong at Duke, who further, correlates with us. And then likewise, we published at the bottom there in the Journal of Urology in 2024, implementing and optimizing universal germline testing for patients with prostate cancer in clinical practice consider. So I'm showing you all this as I showed it at the plenary. This is not me, Neal Shore, with some sort of Don Quixote, screaming at windmills. This is very embraced, and it's time, I think, for the guidelines to embrace universal. Why is that important? Because if you put it into your guidelines, AUA, ASCO, NCCN, then the payers must pay. Next, please. So here are some of the conclusions of that JCO paper. Guideline-directed germline genetic testing is underutilized. The testing are worse among the non-white population. Reliance on family history is a barrier and often incomplete and unavailable. Histologic features, these are more aggressive forms, are very much subject to inter-observer pathology variability. It saddens me, having been in practice now for nearly 30 years, I've watched many qualified, board-certified pathologists when I get second opinion. I use Hopkins routinely and other places, completely contradict the local community read. And it has very significant implications, clearly not only in genetic testing, but in other therapeutics as well. Next, please. The family testing part is key. Think about this: ovarian, pancreatic, endometrial. The vast, overwhelming majority of those patients present with metastatic disease. So if I'm 75 years old and I've got a BRCA prostate cancer, and I can diagnose that ovarian cancer in my daughter before it becomes metastatic, 85% of ovarian cancers present metastatic. But if I could diagnose that early and we can do a prophylactic oophorectomy, wow, you don't need to do a budget impact model to see the benefit of that. Likewise in pancreatic cancer, endometrial cancer. So our conclusions, you can just, if this is a build slide, my apologies, just put them all out there and then I'll be done. I probably went over, I apologize. You click, it's a build slide. There you go. Guideline specific germline testing must be adopted for all. This was our conclusions at the end after doctors Ball and Black presented on bladder, and kidney must be adopted for all malignancies due to prognostic, therapeutic, and familial implications. Somatic testing is increasingly required in metastatic disease. There's underutilization, and universal germline testing may be the future. I wanted it to be a little bit more hardcore, but my colleagues said you got to be a little bit more diplomatic on this one when it came to prostate cancer. So, next slide, and that's my last slide, is the time is now, and that's how I concluded it at the plenary. Thanks very much.
Hey, Dr. Shore, thank you, especially making it pretty much on deadline, but thank you for sharing. We are a little bit behind now. Um, we have one more speaker. A little bit about Dr. Neal Perlman. Dr. Perlman is medical director of Colon Cancer Alliance Research and Education for Lynch syndrome. Dr. Perlman is a Chicago-based internist. He is also a patient with Lynch syndrome. And recently, did a run-in on prostate cancer testing. I don't know if it fits into that. But Dr. Perlman taking on some of the issues with laws involving the insurance industry. So, Dr. Perlman, the floor is yours. And then we'll go to questions and answers afterward. And I hope the speakers might be willing to stick around a little bit. So,
thank you, Howard, and for everybody else's interesting talks. So I'm here as a physician and a patient, and I have to, start with a little bit of family history about the hereditary cancer syndromes. So most people have never heard of Lynch syndrome in their lives, and it's been mentioned a number of times already today. There's about 1.2 million people in our country with Lynch syndrome, yet 95% of people with it don't know they have it. Another of the hereditary cancer syndromes is the BRCA gene, which raises the risk of breast cancer, as it was discovered. There's about 1 million people with the BRCA gene in our country, so Lynch is a little more common. So my family history with the cancers started with my mom, who had both colon and uterine cancers. But she smoked 2 packs a day of Marlboros, so I actually blame Philip Morris for her cancers. And I finished medical school in 1989, and the Lynch genes and the BRCA genes were discovered in the early 90s. So this was not part of my medical school education. But because my mom had colon cancer at 52, the current guideline at the time was to start doing screening colonoscopies 10 years before or age 42. The normal screening at that time was age 50. Because of some other stuff, I actually started at age 40, a little bit sooner. And then instead of going every 3 years, as I was advised, I was actually going every 2 years. So I had 40 and 42, had a polyp at 42. And then my younger sister called me when she was 41. She was having horrible symptoms, and her doctor said she had irritable bowel. And I talked to her and I said, you need a CAT scan. And long story short, she had stage 3 colon cancer, and she passed away a year later. So then when I was 44, I was having my routine screening and I had no symptoms. I had completely normal labs. And I was also stage 3 colon cancer, which wasn't good. So, so with stage 3, you can't just have surgery. You also have to have chemotherapy. And with chemotherapy, there's a drug called the platinum-based drugs, which work pretty well for colon cancer, but about half the people get neuropathy from it, which can cause numbness or severe pain. And about a quarter of the people that, with neuropathy get severe neuropathy, which can affect their day-to-day life. And unfortunately, I'm in that I'm in that pathway. Now, my older sister was having female symptoms, and she wound up with uterine cancer. And her physicians, there was a delay and lack of knowledge of Lynch syndrome, which also causes ovarian cancer. So she wound up having two surgeries, one to remove the ovaries and one to remove the uterus. So because of all the lack of knowledge in the physician community, along with the regular community about Lynch syndrome, we started an organization, a nonprofit, the Colon Cancer Alliance Research and Education for Lynch syndrome, to educate both families and the healthcare community about Lynch syndrome, because it's important to make people aware of it. Since if you get diagnosed early with colon cancer, instead of needing chemotherapy, you can just have a simple surgery or just having a polyp removed. And if you don't have that knowledge that everybody in the family has to be tested, that can cause a problem. In fact, there was a doctor at my hospital who his dad had colon cancer in his 60s. So, he said, "Oh, I'll get colon cancer. I'll get screened at 50." And so he did it 51 because he was a busy guy. And then it was okay. He says, "I'll go back in 5 years." And he went back in 6 years. And then it turns out he had colon cancer. And then he got tested for Lynch syndrome. And then he found out he had Lynch syndrome. He told his mom, because his dad already passed away. And she goes, "Oh, dad had that." And so he's a physician, yet he didn't know that his family had Lynch syndrome, even though his dad had Lynch syndrome. And the reason why I mention this is if you have Lynch syndrome, because there's such a high risk of colon cancer, in fact, 70% of people get colon cancer, 70% of men, 50% of women. You can't start screening at the normal age of 45, you start screening in the 20s. And instead of going every 5 to 10 years, you're actually going 1 to 2 years with Lynch syndrome. Below the age of 40, it's usually every 2. Above the age of 40, it's every year. So if I had known I had Lynch syndrome, instead of going every 2, which I thought was aggressive, I would have gone every year, and I would have had a polyp, not stage 3 cancer. Now, now it's called Lynch syndrome because Dr. Henry Lynch figured this out. And he is a physician and a geneticist who was in Nebraska interviewing all these families with colon cancer. And there was a known hereditary colon cancer syndrome called familial adenomatous polyposis, or FAP for short, where people in their 20s would get hundreds of polyps. And there were these families that were getting colon cancer in their 20s and 30s, but they didn't have hundreds of polyps. They had one polyp. So it was called hereditary non-polyposis colorectal cancer. And that was the name for it for a long time. And then Dr. Lynch figured out that these people that got the families with colon cancer also had a risk of uterine cancer and ovarian cancer and prostate cancer and brain cancer. So at the time, there was no genetic testing for it. So they came up with something called the Amsterdam guidelines or Bethesda guidelines, where if you have multiple cancers in the family and one person was below the age of 50, you're at risk of Lynch syndrome. Now, I got diagnosed in 2008, and at the time, each gene was over $1,000 to be tested. And if you're testing 5 genes, it's like $6,000. Now you can get the whole Lynch panel for $250. You can get the whole, the BRCA and the Lynch genes for $250 and a bunch of other tests. So it's gotten incredibly affordable to test for families. And one of the things we do, at Seek Care is we're trying to make sure that if you have these cancers in the family, and someone has Lynch syndrome, you want to do the cascade testing or test the whole family up and down the family tree to determine who's at high risk and who's at not high risk. Because if you have Lynch syndrome in the family and someone had colon cancer at 40 and they had Lynch syndrome, well, the people with Lynch syndrome have to be tested, starting in their 20s, and they have to go every 1 to 2 years. And the people without Lynch syndrome have to get started at 45. So it completely changes who has to be aggressive and not. And then because women with Lynch have a 70% lifetime risk of uterine cancer and an 11% risk of ovarian cancer, it's recommended when they're done having kids or around the age of 40 to get a full hysterectomy, take the uterus out and ovaries out, because the number one symptom for ovarian cancer is nothing. So if you take it out preventatively, it prevents the ovarian cancer. And if you have a 70% risk of uterine cancer, you're probably going to get it. So then, get it out. So one of the things we're trying to do is promote research. So we're working with an organization, the American College of Gynae Oncology, and we do a little research award for a young researcher. And then there's another organization that we work with. It's the abbreviation is CGAIGC because it's the Society of Gyne. I'm sorry. It's the Collaborative Group of the Americas of Inherited GI Cancer. So it's another very long name that we work with, and we do a 2-year research grant, with every 2 years. So we're trying to promote research with that, but we're trying to educate both, families, and we're trying to educate physicians about this. And our website's divided into 2 sections, with a simpler version for families and a more complex version for physicians, because there's 5 different genes and each risk factor differs based on the genes. So we kind of delineate that out on the website, but we don't want to make it too complicated, for the average person. We're trying to make the main goal of early testing. Now, this is about prostate cancer. And so because of, the family risk symptoms and, colon cancer can increase, I got diagnosed with colon cancer. That's how I figured I had Lynch syndrome. I'm not going to get uterine and ovarian cancer, but there's also a risk of prostate cancer with Lynch syndrome. And of the different subtypes, the MSH2 subtype, which is what I have, has a higher risk of prostate cancer. So I started having symptoms, of nighttime urination, delayed stream. And then my PSA test, was like in the 1s, and then it went up in the 3s. And it turns out that if you have a family history of cancers, such as the BRCA gene or the Lynch gene, you start worrying if the PSA test is 3.0 or above instead of 4.0, which is for the normal population. So a year and a half ago, I had a biopsy, a prostate, which was a lot of fun. And fortunately, it was negative. And then this past year, I started having, more symptoms, and my PSA went even higher. And there's something called a free PSA test, which isn't free, but it's a percentage of a certain subtype of PSA. And that was also worse. And then I had a MRI, and that was abnormal. So I thought for sure, based on the MRI and all the tests, that I was going to have prostate cancer. So I had another prostate biopsy a few months ago, and fortunately that was negative. But prostate biopsies are not fun, and there's side effects from those. So what I'm trying to do is let people know that, for like the BRCA gene, and was discussed early, is the BRCA1 just as bad as the BRCA2? No, it still increases the risk a little bit. but the BRCA2 gene increases the risk of prostate cancer, pancreatic cancer, also male breast cancer, and along with definitely female breast cancer. And the BRCA and the Lynch are both what's called autosomal dominant genes, which means one parent has a 50-50 chance of passing this on to each child. And so it's important to realize this, and most people have no symptoms whatsoever until they get the cancers, and the cancers tend to be more aggressive than the general population, with both, all the different ones with the BRCA genes and the one with the Lynch, and they grow faster. So if you're aware of the genes in the family, you can then do the proper screening to prevent problems. As I said, with the Lynch genes for the female symptoms is preventative hysterectomy and oophorectomy, but it's also being aware of the risk and discussing this with your physician. For an example, if a woman has, uterine spotting mid-cycle, which is very common among women, normally what happens if you see your doctor, the doctor would watch you after a few months, put you on some hormones, and then after another few months, do a biopsy. So your biopsy is usually at least 6 months after symptoms. But if you have Lynch syndrome and you have mid-cycle spotting, you go right to biopsy because the risk of uterine cancer is so high. So being aware of the risk is also important. With Lynch syndrome, there's also a risk of bladder cancer and ureteral, which are the tubes from the bladder. And if you have blood in the urine, a lot of times, we'll recheck it. But if you have Lynch syndrome, you can't recheck it. You have to do a scope of the bladder. So in my case, I also had blood in the urine, so I had to have a scope also, which was also surprisingly negative. So although I'm happy I've just had colon cancer, my risk is very high for others, and it's important to, do the correct screening to prevent getting a delayed cancer. Now, the other thing I'm trying to do is, raise awareness of the testing, and I'm very happy the testing went from $5,000-6,000 down to $250. The problem is, if you get testing, there is discrimination in life insurance and disability insurance. There was a law passed in 2008 called the GINA Act, or the Genetic Information Non-Discrimination Act, which was a federal law which prevents health insurance from being discriminated against genetic testing. But there's no protection for life insurance, disability, or long-term care insurance. Now, in Florida, the former Senate president had childhood cancer. So he was able to get a law passed that protects Floridians from insurance discrimination there. But in Illinois, there is no such law that's been passed yet. Now, there are two laws, one in the House and one in the Senate, that went up for vote. The House Act has gone in and out of several committees. The Senate bill hasn't gone anywhere. It's been stuck in committee. So I just posted them in the chat. And if you have a minute, just writing a short note saying, hey, it's very important for genetic testing to be done and prevent discrimination, please try to get these laws passed. And the laws are not as good as they could be, but they're the only ones that are out there right now. And when I talk about, it's not just cancer that's important, there's something called precision medicine, where you're able to identify the genes of the body and figure out what diseases you're at risk for. There are heart conditions that can cause heart arrhythmias. And you hear about these young kids dropping dead in sports. They're in their teens and 20s. A lot of times they have a heart condition that's genetic, that if you know about the heart condition, you can then have testing, you can get a defibrillator, they can have medicines or restrictions so they don't die at a young age. There are also certain medicines that need certain enzymes to work. And if you don't have those enzymes in the body, they don't work. So you don't want to be taking a heart medicine that prevents you from getting a clot in the body, spending 200-300 a month for it if it's never going to work for you. Or you don't want to take an antidepressant that takes 2 to 3 months to work, that's never going to work because you don't have the right enzyme. So I think everybody at the age of 18 should have a massive genetic test done to figure out everything that they need so we can do proper precision medicine on people and treat them appropriately, screen them appropriately for cancers, for heart conditions, and make the adjustments. But with discrimination on insurance, it causes a problem. And I don't like telling people, oh, well, move to Florida, you can get insurance. That's not my best medical advice. But unfortunately, that sometimes is the only thing you can do if you're trying to get life insurance or disability insurance. So we're at 12:30.
Yep, we're late.
Yes.
So why don't we try, I hope the three speakers can stick around at least for another 20 minutes or so, and we can get some more questions answered, if that's okay with you, Dr.
It's fine with me.
Okay, I do want to take note that I did a survey of 100 readers of my newsletter, and we sort of talk about genetics here a lot, and so it was great to have speakers in who are knowledgeable about it. But of 100 people who responded to a survey, 66% had germline testing. So maybe I need more readers or something. Any rate, I have a couple of questions, and then I'll move over to Jeff and David. Okay. Let's see. Dr. Shore had brought up in his speech the politics of urology, but there, but I'm wondering in general, how well accepted is genetic testing among urologists and medical geneticists? One of the people who responded to the survey basically said his urologist said genetic testing is not useful. So anybody who wants to respond, Dr. Shore?
Well, that's a great example to have a licensed physician today. Sorry, trying to move to a quieter place. But to have a licensed urologist or anyone who's treating cancer patients today say that genetic testing is not useful is obviously not keeping up with their education and not keeping up with the literature and not keeping up with the guidelines. So as Dr. Perlman said, there and Dr. Paller as well, there's really kind of three key reasons, right? And in almost every solid tumor, not even just in prostate cancer alone, is there's clinical utility. There are approved therapies specific for certain genetic alterations, full stop. And you couldn't know that if you didn't get tested. So that's number one. Number two, the implications to family members or what's called cascade testing is incredible, because if you can discover an early localized disease or do something prophylactic or increase your surveillance for a family member to spot their pancreatic or their male female breast cancer or prostate cancer early, or their ovarian cancer early, their colorectal cancer early, that's incredible. And then the third reason is the world of clinical research. Clinical research is it's very important for people to recognize patients who enter into a clinical research study. That's a standard of care. It's not equivalent to saying I'm a guinea pig. That's a standard of care, and that's how we advance healthcare. So those are the three reasons. And unfortunately, that comment from that urologist is not that uncommon. So that's where we have educational work to do.
Gotcha. Jeff, how about another question or two?
Yeah, I have a very insightful question here from gentleman. I've got to tune it in here because the thing jumps around. I think Alan says, he says he's already diagnosed. So why should he have a genetic test now? And he mentions Germline, and I might add to the question Somatic for any of our fine panelists.
Can I answer that?
Please.
So if you have the BRCA gene, and let's just say you have BRCA2, and that caused your prostate cancer, you're at risk also of pancreatic cancer, and then your family members are at significant risk of, breast cancer, pancreatic cancer, prostate cancer, and they have to be identified. So the risk is very high for family members. So it's important to do the cascade testing, and you have to look at each person with cancer and you say, what can I learn from? So if you have colon cancer and you're 42, so you're at a young age, you definitely should get, hereditary cancer testing. And then if you do have Lynch syndrome or familial adenomatous polyposis, your whole family has to be tested to determine, the risk. And you could catch a family member's cancer, much earlier. There was a girl that called us up. She's 24 years old, and her brother, 29, with colon cancer, first cousin, 31, with colon cancer. And they have Lynch syndrome in the family, and the mom knew it, but didn't tell anybody. And it's heartbreaking that those cancers could have been caught early had they done the cascade testing, but she was embarrassed about it, so didn't do it. And there's other reasons for not doing it, but you're putting your family member's life at risk by not.
Jeff, can I interject something here?
Yes, yes.
I think at least one of the people brought it up. I mean, and I think Dr. Perlman had mentioned, the federal law uh, for privacy and protection of your genetic information. I remember myself going with genetic information to my doctor, and was an internist. The one I've gotten a new doctor, and he had the deer in the headlights look. Genetic information. You want me to include it in your file? I said I thought it would be a good idea. And he said, I don't think you want to do that. So I wonder about two things, in terms of the law, how useful it is, how protected we are. We heard about some gaps with it already. And secondly, major concern in the survey I ran about accuracy of the test. So maybe Dr. Paller or one of the other doctors could address privacy and accuracy issues.
I'll take first stab at it, then maybe Dr. Storr can back me up. So privacy is a big thing for all of our patients. We want to ensure that your payer, that your company for which you work does not hold this against you, whether they're doing it legally or illegally in whatever state you live in. And so we take that very seriously, and we keep everything privileged. We do not share it with anyone you do not want us to share it with. I don't know that is always true of other generally available genetic testing opportunities. So that is always something you need to review before you sign on and give your tissue away. And right, so that would be one. And then, sorry, privacy. And what was the other one?
The accuracy of the testing.
Accuracy. Oh, yes, I could go on and on and on. So my a good friend said the other day, "Oh, I've already done an over-the-counter test. I won't name names that have been broken into and have no cybersecurity protection. But I'm all set. I didn't test BRCA positive, but my mother had breast cancer, and her sister had pancreatic cancer. So I don't need to get any genetic testing. But they're not around to tell me anymore. So I'm just saying there's situations like that where people are falsely reassured by poor, incomplete tests that don't test all the potential variants, pathogenic variants, and that are advertised widely with good marketing departments that do not cover what we need to test. So it's really important you get a standard genetic testing done and somatic testing done if you have cancer to make sure you don't carry one of those genes that could put you or your family at risk. Dr. Shore, do you want to add to that?
Yeah, that was very well stated. I think this fear of insurance denials, employment denials, and also the Veterans Association, interestingly, has some problems with it, is a canard that a lot of urologists and medical oncologists, but like that example of someone saying, well, there's liability and insurance issues. I'm just not going to do it. And that's why if we had it universal, that everybody got it, this would do away with much of these issues. Just by the way, in the United States, if you get your test at a reputable lab, I think there's 3 very good ones, and I'm not promoting any one of them. The 3 that it's the Invitae LabCorp, the Myriad, and the Ambry. Ambry was just purchased by Tempus. They're not these kind of commercial social media sites. These are 84 gene panels with excellent genetic counselors. If you go and get tested there for the $200, which at max, or maybe $250 in Chicago, maybe it's more expensive there, and you're positive, they'll do a test on your family members for either nothing or $50. That's a heck of a deal, and guide them with counseling. Of course, you can get onto the Promise Registry and get it for nothing. So the cost, the worry about the insurance people and employers, I find it somewhat appalling, because the information, if you are in that 10%, is so incredibly valuable. By the way, it's a one-time test. Somatic is different. Genetic is a one-time test with reputable sources.
Gotcha.
Okay. Howard, I have if I can incline right here.
Yeah.
I have one of the things that ASPI is predisposed to, and it's very positive, and this is for everybody, is we believe in mutual decision-making between the practitioner and the patient. Now, I had the awkward moment before I got my genetic test with my general practitioner. That person said, I don't know anything about genetic tests, and he wouldn't let me have one. And then, I got smart and went online and didn't buy a car or anything, thank God. But I found out that these genetic tests were available and the family history. So I want to ask the panelists, is there some way we could join our practitioners together with the patients so we're all on the same wavelength in a positive way? All right, too much.
Well, while we're thinking about that, Jeff, I think we all want that. And I think Dr. Shore mentioned that. He said that he would really recommend that the doctors get on the bandwagon with genetic testing. I think all the speakers are really pushing that. I had a couple of questions here on the Lynch syndrome. How do you test for the Lynch syndrome? Is that a blood test?
You could do blood or saliva.
You could do blood or saliva, and it's considered a genetic test, right?
It's a genetic test. There's 5 different genes they test for, but normally, I mean, what it's recommended you do like a whole, like the panels have gotten, you can get like 30 genes or 50 genes all for 250. So, you could go to Color Genomics, which is one of the companies that will do a genetic test by mouth swab, and they have a genetic counselor as part of the money. It's actually about $300 now. And
so the Lynch, sorry to interrupt, Neal, if you don't mind, go ahead, finish your statement. I just wanted
the Lynch is part of that test.
That's
So
what
like
I
Color
yeah.
Genomics panel, they'll also test you for like familial high cholesterol and some other, medical risk, tests. So, I mean, Color Genomics is a nice one. Invitae is a great company, or Myriad Genetics. And if you ask them for like the $250 price at the time of ordering the cash paying, they'll do it. Otherwise, they'll bill the insurance companies $2,000 to $3,000. But most of the time, you're only paying like $250, for the test. But everybody's insurance company is a little different. But if you ask them $250 price to begin with, you'll get that price.
Okay, question. What percentage of people that have this Lynch syndrome can get prostate cancer? How does it relate to us at the prostate patients?
Yeah, so it's a good question. The risk is like 2 to 3 times higher than the general population
Okay.
for getting prostate cancer, and then you can get it at a younger age. So, and it's a more aggressive cancer.
Thank you so very much. This has been really, really helpful.
Yeah, so I put in some data about the BRCA gene. So it depends on your ethnicity. African Americans have the highest risk with like the BRCA gene, the BRCA2 gene. Asians have the lowest risk. Asians and Pacific Islanders have the lowest risk with it, with the BRCA2 gene. So it's yeah, and then the aggressiveness of the cancer is also higher with both the BRCA gene and the Lynch genes.
Thank you very much. I had one more question, Howard, if I could, of Dr. Paller. We're recommended a lot to do genomic testing once we have a biopsy. And I just wondered if one of you, maybe Dr. Paller, could tell us the distinction between germline and genomic.
So genomic is often used to mean your entire genes, and it's used in the context of somatic. People often switch it in terms of somatic of what your cancer has. You cannot pass it down to your kids. But people do switch it around. So you got to make sure they're using it right.
Thank you. Thank you
Yeah,
very much.
well, and sort of as a follow-up to it, and we should probably call it a day soon. But and Dr. Paller, maybe you'd be the right one for this as well. We encounter patients who have multiple somatic or genomic tests. Is that necessary? And I'm talking about not after a second or a third diagnosis of a cancer. I'm talking about after a first one. Does it make sense to have multiple tests from different companies? And, is it a good idea for people with Gleason 6 to have this test? I thought it was mainly used, to decide on treatment versus non-treatment for Gleason 3+4.
That's right. So people use it widely. I just was reviewing a paper on area deprivation index, and 25% of the time, as it's Dr. Shore, and I think Perlman mentioned too, academic centers upgrade or change the grade because they missed looking at slices. So it might be 3+3 at the community hospital, but then it's 3+4 when we look at it. So I put that caveat in there. But Howard, you're right. People overuse them. You don't have to get it done. You're unlikely to have a mutation if it's not higher grade. We've published a paper showing that, Gleason 8, 9, 10 are more likely to have these mutations, BRCA specifically, than patients with lower grade prostate cancer. So definitely you have to take that into consideration. But there are many variables in this process in terms of the quality of care, where you live, who you see, all of those things.
Okay. Jeff, any other final questions?
Yeah. Well, I'm going to shoot the moon here, as I always do, being Irish and pushy.
Well, can I say one other thing to answer that, Howard?
Yes.
Decipher. My favorite thing that makes me laugh is my patients say, I don't need your genetic testing promise thing, Channing. I just got Decipher when I radiation oncology. That tested all my genes. And I'm like, well, it tested some of them. So unfortunately, the market is really broad. And so sometimes you do need multiple one step. But so for low risk, don't get it done. As we go through the stages of cancer, we're going to need different ones for different reasons. They're competitors, that kind of thing. So I just wanted to throw that out there. Okay, sorry, go ahead.
Okay, Howard, just a brief foray into the forest here. I looked at epigenesis. I'm not sure of the definition, but what I'm trying to get at for all of our wonderful panelists is, what do environmental factors that we know of have on our genes, both our germline and our somatics? What I'm getting at is not just chemical problems, but possible radiation that could get into our body and possibly cause some of these cancers. What do we know?
Dr. Perlman, do you want to take that one?
Well, with Lynch syndrome, there's actually, the body has like a spell checking device. So when you copy a gene, you want to make sure the new DNA is a perfect copy of the old one. And you have something called the mismatch repair mechanism, or it's a spell checking device to make sure that the new gene is correct. And with Lynch syndrome or with the BRCA gene, the spell checking is goofed up. So that can cause a problem. If you have radiation, what happens is you actually, poke a hole through the DNA by, burning it out. And you can, you miss something, and that can cause a problem when you're replicating. So radiation's a little bit different. If you have certain chemicals that can cause damage to the DNA, and then when you copy it or you're trying to make a protein from it, it doesn't work right. But
Well, I think I have one final question, and somebody sort of
Wait, can we just go over the common causes that we should all know about real quick? So that was beautiful. Thank you, Dr. Perlman. BRCA also has repair genes. So when things are injured and they can't repair well, it also puts you at risk. So things we know about is high fats diets, especially from red processed meats, high dietary intake of calcium, low fiber fruits, sort of what's good for your heart is good for your prostate. That blackened protein, blackened meat on the grill that my father loved so much is also not good for us. It's a carcinogen for your prostate. Agent Orange, we know, may have increased rates in why veterans sometimes. Smoking is not good for you. Vitamin D deficiency. So those are some of the things I talk about. So a healthy Mediterranean diet is important. Don't smoke, don't overdrink, and try not to expose yourself to too many chemicals.
Okay, well,
the other thing you can do is schedule exercise.
Yes.
And you don't have to be running a marathon and win it. You don't have to, your time isn't important. It's the time you spend scheduled exercise, whether it's walking or bicycling, whatever you want to do, schedule it in and do it every day, at least a half hour, but try to get up to an hour. Every study on exercise has shown a drop in the death rate. So, and it helps with cancers. So it's very, very important to schedule activity.
two quick things here. Tom raises a question. Dr. Paller, do we need a physician order to order your test?
No, that's what I love about it.
And
You can go directly to the website. You don't need to talk to me. You can do it yourself and keep your own doctors.
Okay, one last question. You can get a test of BRCA from 23andMe. It's included, and they have a certified lab. But I get the sense that many physicians look down on that sort of testing for genetics. Do you see anything?
That was the one I was implying without saying its name earlier. It is not.
But they're certified.
Any of the other ones we mentioned are 10 times better and more comprehensive.
They
They will falsely reassure you.
Gotcha. Well, you guys were great. I'm sorry that Dr. Shore had to skip out. He's probably going crazy in the airport. So we'll take pity on him. But thank you, Dr. Perlman. Well, we're getting some applause from North Carolina on there. I saw that. And thank you, Dr. Paller. It was a long stretch. Well, we're getting lots of applause here. This is something new. So, well, I'll applaud you the old-fashioned way. Any rate, thank you both very much. And this will be posted online, and I'll let you know when it is. So, thank you. Wow, you guys are a hit.
Yeah.
Happy Saturday, everybody.
Yeah. You'll have some more fun. There's nothing
Yes.
more fun than prostate cancer, but take a break. So, thank you.